Thank you all for joining us, and thank you to the Boston Globe for its important ongoing coverage of our region's healthcare sector. Boston's healthcare landscape is well known for educating and training the best clinicians in the world, and for fostering some of the most important innovations in medicine and breakthroughs in life sciences, all of which contribute to improved outcomes and a better quality of life for patients and families everywhere. I'm Dan Sensi, CEO and managing partner of the newly rebranded Issues Management Group. We are the same integrated strategic communication, public affairs, and digital firm providing senior level counsel to clients at the intersection of public policy and business, only with a new name and brand. We are proud to partner with the Globe to bring thought leaders and important conversations like this one to the table. I am honored to present this panel examining one of the most important issues the healthcare industry faces today. How will digital health ultimately impact health equity? Will it help or hinder? We know far too well the toll the pandemic has taken on our communities. Loved ones lost, businesses shuttered, lives upended. The pandemic also served as one of the most potent accelerators the healthcare industry has ever seen. We set up field hospitals virtually overnight, ramped up testing at breakneck speed, and ultimately developed a safe and effective vaccine faster than ever thought possible. The two issues brought to the forefront by the pandemic that may have the most lasting impact on healthcare are the widespread adoption of telehealth and the exposure of the inequities that exist in our healthcare system. Telehealth was basically invented here in Massachusetts, so it was no surprise that we became among the fastest to adopt and utilize digital health tools. The technology offered a much needed lifeline for those in need of clinical care, particularly those needing behavioral health services. At the same time, the pandemic exposed the inequities that exist in our system and how they disproportionately impact communities like Chelsea, Brockton, Springfield, amongst others. Today, our experts will examine how the advent of virtual care has impacted marginalized communities and what we can do to provide better care online and in person for all. How do we make certain that new technologies help reduce inequities and not exacerbate them? How do we address issues of digital literacy, cultural competency, and inconsistent access to broadband? In short, how will healthcare leaders, technology experts, and community organizers alike partner with government and public policy crafters to ensure that these new tools provide for greater access and equity? How will they facilitate needed structural changes in healthcare access and ultimately build upon the greatest healthcare delivery system in the world? Now, it's my pleasure to turn things back over to Anna to introduce our panelists. Anna?
Thank you so much, Dan. Good morning, everyone, and welcome to our panel on health equity and the future of virtual care. I'm so grateful to all of you, our audience, our readers, for joining us. And thank you so much to our panelists, Christina Severin and Dr. Jennifer Joe. During the course of our discussion, if you have a question, we encourage you to please ask questions and ask them throughout the panel. In the Q&A function, you'll see at the bottom of your screen, there is a Q&A button, and you can press that and enter your question in there, and we will pick from those later on in our discussion. So before we continue, let me just welcome again Christina Severin and Dr. Jennifer Joe, and I'll ask them to introduce themselves before we get started. Christina, let me start with you.
Good morning, Anna. Thank you, Dan, for that lovely introduction. Thank you, Anna and the Boston Globe, for having me here this morning. Welcome, audience. Really looking forward to engaging with you this morning, and particularly in hearing your questions. So thank you for submitting those questions. My name is Christina Severin. I'm the president and CEO of Community Care Cooperative. We're a nonprofit organization domiciled here in Massachusetts. And what we have done over the last several years is to get a bunch of federally qualified health centers together to scale up what we do. We do value-based contracting. We work with Medicaid in Massachusetts, and we aim to improve health outcomes for people who have Medicaid while at the same time effectively managing the medical expenses involved for that population, in addition to many other things that we do with federally qualified health centers throughout the Commonwealth. And I'm delighted to be here this morning to talk about telehealth.
Thank you, Christina. Dr. Joe, can I ask you to introduce yourself next?
Hi, thank you, Anna, and thank you, Christina, for sharing this and setting the stage of what we're going to talk about. Really a pleasure to be here, and thank you to the Boston Globe for hosting and for everyone being here. I'm Dr. Jennifer Joe. I'm the chair of the Massachusetts Medical Society IT Committee. We helped write some of the initial AMA or American Medical Association telemedicine reports. I'm also a digital health expert where I've been mentoring and advising different companies for the last 10 years. And then most recently, I'm doing some digital health virtual clinical trials at the VA, the Veterans Association Hospital, where I am an emergency room physician. So that's my introduction. Very excited about this topic. I'll toss it back to you, Anna.
Thank you so much. Thanks again to both of you for joining us. Let me start by asking each of you how the pandemic has changed your use of telehealth. Christina, let me start with you. How much did your clinics use telehealth before? How did that change during the pandemic? And where do things stand now in terms of how much you use it and how you use it?
Yeah, so before the pandemic, we had a very intentional strategy of moving X% of visits to telehealth. And every year when we went to evaluate our performance against those strategic targets, we had just failed. It was really, really hard to move the needle on getting sort of the change management needed and getting through that to getting to a different place. And then the pandemic happens. And we made more progress in progressing patient access to telehealth modalities. And by that, I principally mean video, what we're doing right now, but also telephone. We made more progress in 2 weeks than we had made in 4 years when the pandemic started. And that was the good news and the bad news. When the pandemic started for the federally qualified health centers, the first thing we needed to do was to figure out how to get primary care providers and behavioral health providers laptops. There was a lot of disruption. Our viewers may recall the supply chain disruption from China at that point, which is where many of these computers come from, certainly not all. So figuring out how to get those computers, how to deploy those computers, how to configure those computers, and then figure out how to create the scheduling systems and the technology systems needed to connect doctors, clinicians, and patients, bringing applications that are pretty widespread right now. For example, there's a company called Doximity, which would allow a provider to do many things. For example, use Doximity to place the call to a patient for a telehealth visit without displaying their telephone number. So within, let's say 2 months of the pandemic starting, probably less, we had moved virtually all visits other than what was needed for very acute care and for COVID testing and treatment purposes to telehealth modalities. Flash forward to today, we knew when everything went to telehealth, we're like, this is great, this is not great, this is a pandemic, this is awful. In terms of progressing telehealth, silver lining, it's been good that we had a forced adoption. And let's think about what's going to happen when the pandemic starts to recede. We didn't know when that would be, but we knew it would happen. And what we wanted to do, our fear was that when the pandemic receded, all telehealth would also recede and we would go back to 100% face-to-face visits. And so when we went into telehealth, we went in saying, how do we develop sort of a desired mature state of telehealth so that when we go back to whatever the new normal is, we've concretized telehealth as part of the new normal and we don't recede back to 100% face-to-face.
Great, thank you so much. And Dr. Joe, same question. How has the VA used telehealth differently during the pandemic?
Sure, absolutely. And Christina, thank you for your perspective. And I think the VA And I am going to say I work at the VA. I do not make our IT decisions or telemedicine decisions, but I've been there for now 11 years. So I can speak as to what happened. So the VA, I think it was in actually a very fortunate place in terms of our technology infrastructure before the pandemic. So to put this into scope, we were probably the earliest to implement remote patient monitoring, which we've been using for cardiac and pulmonary patients, so heart patients and lung patients, specifically heart failure and then COPD. We were using this well before the pandemic for the last 10 or 15 years. And additionally, we've had telehealth for specialty visits before the pandemic so that our rural patients could access specialists, so like endocrine or like diabetes specialists and stroke specialists. And we've also been using asynchronous. So asynchronous is sort of when you, it's like email. You send something, you wait for someone else to receive it, and then they receive it and they send it back. So that's asynchronous. We've been using that a lot for dermatology. So where you can take a picture and then have a dermatologist review it at a separate time and place and then get back to the patient. So we had nice infrastructure. I will caveat this by saying the VA is the largest healthcare system possibly in the world. So we have 6 million active patients, 9 million total. And there's lots of VA hospitals or clinics around the country. We're all very different. So we all operate very differently, but the concept that we should be able to tailor it to the local population. I work at 4 different sites in the New England area. But because of our infrastructure, so we already had this technology infrastructure, we were able to flip over all of our outpatient primary care and specialty clinics at Jamaica Plains, which is where we have them, in the first week. So we made that decision on Monday. It was completely flipped over the following Monday. I think similar, Christina, to like, we did it really fast. During this time, we also expanded our technology. So we installed cameras in all the computers and we rolled out iPads in many places. So for example, I'm in the emergency room, and the piece that we don't think about it as much is that we had iPads for all the patient rooms. So remember in the beginning, we didn't know if someone had COVID or not. We wanted to minimize contact. So what we would do is the patient could iPad me from inside the room and I could have this conversation outside the room. We've also used this in the emergency room in terms of having specialists beam in. So infectious disease, which are the specialists, at least at our center, who help manage difficult COVID patients. So at the beginning, before we had Paxlovid, I think the pill for the antiviral, monoclonal antibodies were an IV infusion, which is quite a big lift and something that most ER physicians had to learn. So what we did was we actually had the infectious disease team beam in, see the patients, write the instructions so that we weren't guessing what needed to happen, because those instructions were changing quite rapidly. So that's an example. In terms of, hey, what are we thinking about? I want to just talk about this in terms of where Massachusetts, because Dan made that excellent point that Massachusetts really leads the way for the nation. And we want to think about telehealth access in the whole country and what's happening. As I mentioned, I'm the chair of the Mass Medical Society IIT committee, and we supported a lot of the American Medical Association research on telehealth. So there's a couple of reports that you might see floating around that you can actually find on my LinkedIn. And in terms of uses, Massachusetts consistently has some of the highest use of telehealth across the nation, tends to be ranked #1, top 5. There are other states like Tennessee, Nebraska, Kansas, North Dakota, and Wyoming that have the lowest use. And then to really dive into this more, like how much telemedicine is happening in Massachusetts, from the AMA report, American Medical Association, 84% of Massachusetts physicians currently use telehealth. And then on average, so that's where we are. And then how are we doing this now? On average right now, Mass physicians see about 47 patients per week, depending on your specialty, and 14 of which are via telehealth, to kind of frame where Massachusetts is and where we are now. So we still have a lot of telehealth usage. And as Dan mentioned, Massachusetts is leading the way.
That's great, Dr. Joe. Thank you so much. Those are really interesting statistics, and thank you for putting a great frame on on where Massachusetts stands relative to other states and how much it's being used here. So I wanted to ask each of you about the benefits and drawbacks of telehealth as you see it. So Christina, let me start with you. What do you see as kind of the pros and cons?
I tell my kids if they're bringing me good news and bad news to always give it the bad news first. So I'll start with the cons. I don't think
this
they're
first person.
Oh yeah, absolutely. Always end on a high note. So I would say telehealth and potential drawbacks. I'd say there's not a lot of them. Now, my lens is a lens of thinking about the organizations that are federally qualified health centers and the population served by community health centers, which is a very diverse population and very different characteristics of the population health center to health center. Generally speaking, a population served by a federally qualified health center tends to experience a lower income and tends to serve people who are more likely to be non-white. And so those are some unique characteristics in some health centers. So drawbacks would be that somebody uses a telehealth modality and therefore doesn't get some additional care that could have been associated with that visit if that visit had been face-to-face. For example, a person with diabetes has a telehealth visit. As part of the visit, the clinician seeing that person writes them a lab slip to get their blood drawn to look at one disease marker for people with diabetes, which is their hemoglobin A1C. And because that patient has impediments on getting into clinic, they're not able to come in, pick up the lab slip and have their blood drawn to have their hemoglobin A1C evaluated. That would be a drawback. Now, the flip side of that is that person who had the telehealth visit for diabetes, who didn't get their hemoglobin A1C done, did have an encounter with a clinician. The clinician got information about how the individual was doing, taking their medicine, side effects, any financial barriers in being able to take their medicine, and other factors which may be going on in their lives clinically or socially, which could be impacting their ability to self-manage their disease. That person in the past, if there was only a face-to-face opportunity, might have chosen to not get any care because they may not have been able to get in for care because they couldn't get the time off of work, or they didn't have transportation, they didn't have money for gas, or they didn't have childcare. So, you know, there's pros and cons in looking at this. When we think net and longitudinally, looking at what has happened with access to care and the percent of appointments booked and not kept, we see an increase in access to care and an increase in the percent of appointments kept. And we have not seen any significant decline in health outcomes like overall patients with diabetes. We haven't seen an overall decline in hemoglobin A1C. Fortunately, concurrent to this, we've been able to roll out some really, really important programs in partnership with Massachusetts Medicaid, also known as Mass Health, to provide individuals with social support assistance, which has definitely been a complementary method in ensuring that people have what they need to effectively manage their disease, like the ability to get a medically tailored meal, which could be a finding and a follow-up to a telehealth visit, that somebody with diabetes doesn't have access to the right foods and be able to order and pay for a medically tailored meal for those individuals. And the early results that we are seeing from those interventions are startlingly profound on the improvement in health outcomes and the decrease on medical expenditures.
Thank you so much. Dr. Joe?
Yeah, thank you, Christina. Thank you for sharing. The social determinants of health piece, the access to the right foods is massive. So I agree with you on that. Telehealth is great. It all comes down to access, and also I think we don't quite respect the concept of social determinants of health. And this is a big fancy word that I I think probably doctors use a fair amount, public health officials use a fair amount, but this is like, hey, if someone has asthma and we know that their asthma gets worse in the summer, if we can buy them an air conditioner and control their asthma. And that has huge benefits in terms of keeping them out of the hospitals. Whereas Christina, you mentioned the right diet or access to the right foods. It's just massive. So I want us to think about that as well. In terms of the pros and cons that I see in telehealth, I'm going to just go all out. It's just pros. I see it as just pros. And Christina, bringing it back to what you're saying, I'm just going to say it again. It's access, 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 access. Like we have hospitals that are hard to get to. We have clinics that are hard to get to. We have like go get your blood trials that are hard to get to. We have Dr. Joe's urgent care is only open between 8 to 4, not on Saturday and Sundays. We have to do something big to mitigate this access. And I think telehealth has gone a long way into providing that access for patients. So I had this theory about access and the impact of access. And I was like, I wonder what this is going to show once I look up the numbers. So I think a lot of you might know that telehealth, we've extended some of the benefits or most of the benefits that we got from COVID. But I think Congress, maybe someone will correct me if I'm wrong, said something like, but we need more time to actually measure the effects. And so now we're getting some data to see if we should continue these payments and what they look like and how good or not good they are for the systems. So just February 1st, 2022, report from the Assistant Secretary for Planning and Evaluation on Health and Human Services, massive study, 808,000 respondents across the US. 23% of them reported the use of telehealth service in the previous 4 weeks. That's actually a number that I'm surprised by because that's quite high, which means that telehealth is continuing to go and it's kicking. What is interesting is that the lowest usage was in the uninsured, 9.4%. So I think we knew that we actually need more health insurance coverage to all Americans. If you don't have that, you're just not going to access the system. And then also young adults had some of the lowest usage at 17.6%, which we expect because young adults generally don't say hi to me as a doctor very often. They're like, I'm out playing basketball. I'm not going to go say hi to Dr. Jarrow. What is the most interesting, Christina, and I'd love to hear I think you maybe have already talked about this. So nationwide, the highest rates of telehealth visits were among those with Medicaid at 29%, Medicare at 27%. So just to break that down, Medicaid is the poverty level. So we provide this healthcare access to you. So 29% of those were using it. Medicare is the benefit that 65 and older gets. 27% were using this, which is some of the highest rates. African-Americans or Blacks were at 27%. And then what's most interesting is those earning less than 25,000, which is very low, used it at 27%. So for me, this is profound. It indicates that telehealth has massive benefits for the older, the poor, and those who have we call it social determinants of health. I have difficulty going to the doctor. Everyone has difficulty going to the doctor, but some people are able to overcome that more easily than others. So people who have difficulty getting there, this is great access. I also want us to just break it down because when we think of telehealth, we normally think of video, like WhatsApp, FaceTime, Zoom, we're doing video right now. But physicians have known for a long time that audio is king, meaning it's just an old school telephone visit. So when this report looked at audio versus video, it noted that, hey, who are the people using audio? It's the young adults, 72% of young adults, so 18 to 24, do their visits over video. Those who earn more, so now we're earning 100,000 or more, 68% do those visits on video. Those with private insurance at 65%, and also white individuals at 61%. The audio visits, though, were highest among those with a high school diploma, 65 and older, Latino, Asian, and Black individuals. So when I think we're talking about coverage and access, audio has got to be front and center. I was talking to Christina about this, I was talking to one of the Boston Globe people about this. I did my follow-up visit with my I have a cardiologist now that I have long COVID. So I did my follow-up visit with my cardiologist and my urologist, had my first kidney stone during COVID as well. And they both did audio, and they said, essentially, I'll call you when I call you, which actually is really important for people who have schedules that they can't really take a break from, so they can really squeeze it in. And I think it works for the patient and also the physician.
Yeah.
That's did you want to say something? We could.
Yeah, Anna, if that's okay with you, I just Dr. Joe's thoughts triggered a couple of other thoughts that I had.
Audio, social determinants of health.
Yeah, no, social determinants, social driver is absolutely key. And the statistics that you were just citing very much align with what we have seen in our statistics around people who are non-white and people who are lower income. It's interesting. I don't know, maybe 6 months into this work, into the pandemic, we were looking at our video versus audio rate. And we were about 80-20, 80 telephone, 20 video. Then we heard about Mass General Brigham's rates, and they were exactly inversed.
Oh, yeah.
I think Dr. Joe is aligned with the statistics, that the differences in the population served in the statistics. Other reasons why, in addition to what Dr. Joe said, other reasons why telephone is a highly successful and impactful telehealth modality is because there are many people who don't have access to video. They do not have hardware with a camera. Well, they probably do have a smartphone, and they may not have the ability to burn down the data plan. So we have deployed many strategies to make accessing telehealth modalities, telephone and video, easier for patients. And a key part of that strategy is getting people the tech they need, which may be a smartphone, it may be a data plan, particularly because fascinating when you look at where there are gaps in broadband coverage in this state. You may not, a lot of people might not realize that there are complete dead spots. It's interesting, we did a map and we called the map sort of bridging the digital divide. And we plotted where there were gaps in broadband access and said there was a gap if there were X percent of households who didn't have broadband access. And then we drew a 5-mile radius circle on those areas where there were a certain number of households without broadband. And then we put in where health centers are in the state of Massachusetts. And it's amazing because there's these pockets where there's no access. And then there's a health center that is serving that territory in the state. So this is, again, good news and bad news. We've got a problem, and the health centers are really well positioned to try to solve this. So the FCC was really supportive, and the grants that they gave out, that gave us money for hardware, including wireless, MiFi wireless hotspots. Deploying that and getting that dialed in is another story, and perhaps we'll talk about that. But our experience was exactly aligned with what Dr. Joe was saying, including a very high level of satisfaction with telephone. And when we look at level of satisfaction with video, Black people were less satisfied with video, and we believe that there were lower satisfaction with Black people using video because of the impediments experienced in using video.
Just difficulty getting it turned on. Yeah.
That's
Thank you for
yeah. Thank you so much. Sorry, go ahead, Dr. Joe.
No, go ahead.
Okay, I was just going to pivot a little bit to talk about the technology for monitoring patients remotely, which has really advanced during the pandemic. And so maybe I'll go to Dr. Joe first. You did talk a little bit about how the VA has an advanced system for monitoring patients from home already, but you're also directing a really interesting all virtual clinical trial for long COVID, where you're also using at-home testing and at-home monitoring. So I wondered if you could talk about the different ways that you monitor patients remotely from the VA, and also for this really innovative clinical trial.
Absolutely. So I'm excited to talk about that. I'm going to go back to a con of telehealth, and then I'm going to move into remote patient monitoring. No, so the con, it's just everyone's like, we just don't know what situation to use video, asynchronous, audio, follow-up. So I will say that is what most people will say is a con right now, but it's just we're trying to figure out essentially a new modality and how to put it into medicine. So I think we're just at a learning space. So what am I talking about here? So I think it's a no-brainer that we all say, hey, it's a follow-up visit. It's a hypertension follow-up visit. Or I saw the cardiologist, she called me, she's like, did you get the echo? And I said, no, you said I couldn't schedule out until May. So I have access problems now. But so that's a no-brainer. Yeah, telephone works great there. What sometimes doesn't work for telemedicine, I think we're also figuring out, and I think some of the no-brainer pieces there is, hey, if you need a physical examination, and sometimes the patient doesn't quite know that, and that's confusing to them. But an example might be, hey, if you have something wrong with your eye that typically needs an actual physical eye examination, or if you have a vaginal exam that's needed, that also needs a physical examination. So I think those are clear, but kind of shows you we have a lot of learning still to do. And I think we'll figure it out. But thank you, Anna, to pivoting to the concept of remote patient monitoring and also virtual clinical trials. So I am delighted that we are starting to stand up a virtual clinical trial. We should have the IRB finalized in the next week, and we're looking at post-COVID and post-COVID existence. As I mentioned, I work a lot with startups, and so we have a great startup named ADAR Health that has a breathalyzer. I actually have a lot of breathalyzers just hanging out around my home, but this is a breathalyzer. You breathe into it, it's completely FDA cleared, and you get 10 vital signs. So you get a 1 lead EKG, you get an O2 saturation, you actually get more than you typically do in a doctor's office, and that you can get some of the how much is your lung expanding or not. You can get heart rate, strangely, you can get blood pressure. I want to say blood pressure, but you might need to check me out there, but I think you can from this. And what we're going to do is we're going to drop it in post-COVID patients and actually follow how their vital signs change over time. That's exciting in that it has a lot of possibilities, and I'm excited to be doing it. But to Anna's point, what is a virtual clinical trial and why is it important? And why is it important to health equity? So virtual clinical trials, we, hospitals and doctors, we like to do things in person. We like to give you papers. Classically with clinical trials, we actually have to bring you in multiple times, say hi to you, even though we could have done it over the phone. It's sometimes really useful because there's lots of blood work and maybe some physical exam. But because of the learnings of the pandemic and also this focus on health equity that the pandemic has shown a bright light on, there's a lot of interest in virtual clinical trials. So what does that mean is, how much can we do completely virtual? So for us, we're going to be completely virtual, and that will look at the patients, see if they qualify, call them, finalize that, then we'll mail out the breathalyzers, and then we'll give them a survey. If we prefer for them to do the survey on an iPad or a computer, but if they don't have that, we'll call them and we'll do it over the phone. So we anticipate the possibility of being able to more or less finish the entire clinical trial virtually. What does that mean in terms of patient enrollment and health equity? I don't know if many of you know this, but there's massive health disparities in terms of who is enrolled in clinical trials. Previously, clinical trials were primarily white, male patients, and a consistent underrepresentation of women, the elderly, and people of color. So while people of color make up about 39% of the US, these groups are typically only represented up to 2 to 16% in clinical trials. Why is this important? So as you notice, I am of Asian descent. You might have heard of the medicine Coumadin. So Coumadin, not as commonly used now, but was used a lot. Like one of the greatest things that we had, lots of people on it. Classically, it's we call it a blood thinner, but it was actually classically a white powder poison for rats. So we lead it out, rats would eat it, and they'd bleed out to death. And that's what it was used for before being used for blood thinning. It was approved for use medically in 1951, but it was not until 2013, so almost 50, 70 years later, that scientists realized genetic ancestry impacted the dose of Coumadin. So many people of Asian ancestry required a much lower dose, and they actually suffered excess bleeding when the drug was used at the dosage set in the clinical trials, which were mostly white men. So this just really underscores the importance of representation. And so what does this allow me to do? Once we have adequate representation in clinical trials, hopefully it'll allow me as a physician to say, hey, I can see you have this ancestry, and I now know that this is the drug I should use for you first because it'll work, or this is the right dose for me to use for you first because, you know, we tailor that for you. It's really going to put us into precision medicine, and I know that doesn't sound like precision, but really move the precision medicine bar forward. And I'm hoping that virtual clinical trials will help to close this equity gap, because we should be able to go to you. You don't have to come to us, and it should be less barriers.
I think that's it's totally awesome. Congratulations on that work. There's probably another, and I'm sure you've thought about this, Dr. Joe, on reasons why there's been inequities in representation.
Oh, yeah.
And for some populations, for example, African-American populations, a general distrust of the healthcare system, where participating in a clinical trial might be like the leading edge of distrust given this country's history, with the Tuskegee experiment and other experiments that pretty much intentionally caused harm in the African-American population, and therefore very robust reasons for distrusting the US healthcare system. And so I'm sure you've thought about this, and I think we need to continue to think about what the US healthcare system can do to recognize the harm that was perpetuated against certain populations, and how to move forward in a way that considers what has happened in the past as we try to rectify the future in rebuilding trust. And we see this in clinical trials. We see this in, of course, COVID immunization rates.
Absolutely, hands down, Christina. I'm so glad that you brought that up. Rebuilding trust. What does rebuilding trust look like? What does it mean? I think I'm glad we're talking about it. I would like to see a lot more action and positive steps in that direction. But it is fundamental for us to move forward as a healthcare system and as a nation.
Thanks to both of you. I think maybe I'll start bringing in some questions from the audience, because we have some really good ones from listeners. Let me just start.
Will we be able to answer them? I don't know. Okay.
We'll find out.
They're smarter than we are.
We'll find out. I have confidence in you both. Let's start with the first one, kind of going back to barriers to access. This audience member would like to know, how is telehealth being used to provide access to those with physical and mental disabilities? I thought I might toss that one to you first, Christina. I don't know if you have any insight into that.
Yeah. Let me start with behavioral health disabilities. So behavioral, when the term behavioral health gets used, there's two sort of pillars. One is mental health, and one is people who may have a substance use disorder. So we have seen really, really good success in improving rates of access and consistency of access for people with a behavioral health condition now that we are able to offer telehealth modalities. Specifically, right now we're running with the FQHCs that participate in Community Care Cooperative, we're running at about 40-ish% telehealth visits. Of those, the majority are still telephone, not video. There is some video. Within that 40%, the split on physical health and behavioral health is quite different, where behavioral health has been and continues to be at was 80%, it's about 70-ish% now. And physical health is more like approximately 20%. So patients have found that getting their behavioral health visits, both for mental health and for managing a substance use disorder, has been more effective for them in obtaining access and continuing to have regular access to their clinician through telehealth than it was face-to-face. I think there are many reasons for this. One, of course, back to a point that Dr. Joe made, less likely that there needs to be physical touch during the visit or sort of, penetrating the skin for a lab visit, which if it is needed, right, someone can always come in for their lab slip. I think that there's also some evidence that has accumulated over many, many years around actually when you don't have somebody who you can touch and you take sort of that immediacy out and that level of intimacy out, it can actually create an environment that feels safer for a patient to really disclose, what's been going on with them and have a very successful therapeutic relationship with a behavioral health clinician. So I hope that for the viewer out there who asked that question, I hope that answers your question on the behavioral health side. I think I have less experience on the physical health disability side. I think if my colleagues were on the phone, they would say, yes, that has also been an improvement too. Do we feel like we have addressed all of the access issues related to making access and care easier and really sort of right-sized for people who experience physical health disabilities? No, I think we have work left to do.
So I have something to contribute. At the VA, we have a number of veterans with physical and mental disabilities, whether that's amputation, spinal cord, a progression of diabetes. Now we're getting into mental, stroke, PTSD. So we take care of very high-risk patients. The thing I think we should always remember is that healthcare is a human to human. And anytime you have a human to human relationship or care, software and technology can support it, but it's ultimately going to be that relationship between a human to human. So the way that the VA handles this is that we actually have home-based primary care. So if a veteran is physically unable to get in or mentally unable to get in, we'll put them on the home-based primary care and have a team go out and essentially perform the PCP, the primary care visits. So they usually go out and check on them regularly. They'll take blood, they'll bring it in, they'll take, the medicines are mailed out. That's how the VA system is set up. But that person might also look at all the medicines, make sure they're taking it correctly. We also have hospital at home. I think everyone's heard that we're moving to hospital at home. So this is essentially where you're taking remote patient monitoring. So this technology piece, sometimes layering it in with high acuity patients or sicker patients who would not normally leave the hospital, and you go out and visit them as well. So we use both of that, and sometimes we'll combine it with the technology, the remote patient monitoring, to really support these patients. And we've had really good success with it. Finally, I don't want us to forget, and I say this because our White House Innovation Fellow is a caregiver for her father, who I forget exactly how this happened, but she is a strong caregiver and he's mute. But the caregiver piece, how do we bring the caregiver into this conversation? Can we have the caregiver video watching or checking in periodically on the patient? Maybe have some remote patient monitoring, meaning some way for it to easily be a blood pressure check or temperature check. Maybe that person, the patient, can't actually do it, but the caregiver can go in and do it and perform many of these tasks when we're thinking of supporting patients at home. And I don't think we've done that successfully. So I'd love to see the system involve the caregivers a lot more and actually see that there's a care team on the clinical side, but there's also a care team on the patient side.
Thank you so much. Here's another interesting question from the audience. Warren would like to know if there's any anecdotal information of a social stigma where marginalized populations choose not to use video because it discloses their living conditions or environment. I wonder if you have encountered that at all, people kind of feeling embarrassed or reluctant to turn a video on in their home to show their environment. Christina, let me start with you.
The answer is yes, absolutely. We have a direct experience and specific stories. about that. So it's absolutely an impediment for some patients. And it is not only not wanting to turn their camera on to show the condition of the home, but also not wanting to turn the camera on because of lack of privacy. We have stories about the great lengths that people will go, even video aside, just be able to have privacy to make a telephone call where they may, go to the library or find some nook in their garage or what have you. So yes, I want to get the person's name right who asked the question. Did you, Anna, did you say it was Warren?
Warren Crow, it looks like.
All
Is that right?
Well,
No.
yes, Warren. Yes, absolutely. The turning the camera, conditions in the home and not wanting to sort of bring the world into view on conditions in the home is absolutely an impediment to use of video for some patients.
So I don't have direct experience with that that particular issue. I lead the knowledge translation department for JMIR Publications, which is a peer review open access publication that's been covering and publishing on digital health and telemedicine for the longest amount of time. So I do know that from the papers that we've received, to Christina's point, one of the biggest issues is the patient actually finding a place where they can have the visit or privately have the visit. So specifically women in abusive situations, that is particularly difficult to find a safe place to actually have the visits.
That's great. Okay. How about, okay, since we've been talking a lot about telehealth, there's sort of the other side of the coin, which is not wanting to lose the in-person visits. So Tim is saying, I love the goal to ensure maturity of telehealth, to ensure it continues post-pandemic. It's so important to reach underserved populations that may otherwise not receive care. But can you speak to how to best ensure those things that still need in-person visits, like immunizations, shots, physical exams, are not diminished as telehealth forges ahead? Dr. Joe, do you have any thoughts on that?
So we publish a lot about this, that the importance of the physical exam and how for us to determine on our side, because it's really going to be on the clinical side, when is the most important time to bring a patient in. So we do a lot of publications on about it. We talk about it, and I would actually say that culturally, our preoccupation with the physical exam has held up telemedicine. So I'm not that concerned about it right now because the pendulum's so far over here. I'm just waiting till the pendulum swings a little bit more to the middle because we're still talking about it. And it's still like, yeah, oh yeah, you talk to an older physician, they'll talk about it a lot, the physical exam. So I completely agree that that's important, but I also think that we are only scratching the surface of what's possible with telemedicine. And I say this from a remote patient monitoring standpoint, meaning, hey, if Jennifer is actually going to have a breathalyzer that can get 10 vital signs data points, that's crazy, that's incredible. And I want us to think about this is a telephone visit with someone I've seen maybe once or twice, but I actually have 10 vital signs parameters every day for 30 days. How much more does that tell me about their living condition versus bringing them in for me to do a physical exam in a sterile place when I don't know if they have cats, I don't know if they have rugs, I don't know what they're tripping on, and I'm not seeing them in their actual living environments. So that's the question I want to pose, is that it's untouched, this level of data and understanding the patients where they are and the power of that. Or is that shorter than normal? Or
No,
I can go into what do we need? Okay.
Christina, do you have anything you want to add to that?
Yeah, I mean, I would add, and I think Dr. Joe made this point, maybe a question or two again, around some of this is still evolving. And specifically, like having all of the workflows on deciding what modality a patient should receive based on presentation.
Very difficult.
Is it right? Is it making
Very
an
early.
annual with the patient? Okay, you have, you've got some ongoing depression, you have diabetes and hypertension. Let's talk about the year to come, Like, what do you want to do in person? What do you want to do in telehealth? Let's make a plan. The plan could work. The plan could go sideways. So I don't think that there's anything that is so specific other than what Dr. Joe mentioned around if you have, horrible pain in your eye, yeah, you probably need to come in and have face-to-face care. Well, child visits, I would say most pediatricians are going to say, yeah, I'd be comfortable doing some of that telehealth with strong lab backup, but I want to see those kids. I want to see who's ever parenting those kids. I want to have an exam room. I want to observe. Could you do that through video? Yeah, maybe, but I think you lose a little something of the bond that gets created in an exam room when sort of human beings get together that way to look at their children and talk about their children and love on their children. So I think that I think that nobody has come up with the definitive playbook of the shoulds and the shouldn'ts and the gray area and the clinical pathway on determining use of which modality, when, how, et cetera. I think it's a work in progress.
Thank you so much. I don't know how well you know kind of the insurance landscape, but we have a couple of insurance questions. Here's a question about Medicare and Medicaid. Do Medicare or private insurers limit coverage coverage of telehealth to in-state providers only?
With their so Mass Medical Society has a lot on this. This is what we do. I'm not one of those experts within the Mass Medical Society, but I did briefly read it. But what you're referring to is that there are rules around Dr. Joe's licensed in Massachusetts, but she might be seeing a patient in Minnesota or by telehealth, or might be seeing a patient in Texas by telehealth. There are different roles, and it's dictated by a state about who I can see and who I can't. And hands down, I have to be licensed, or not hands down, I think it's actually variable, but generally I should be licensed in the state that I'm treating the patient. Does not apply to the VA, interestingly enough. So VA is one of the systems where the VA has credentialed you in one hospital and you can go work at every other hospital. And this also applies to telemedicine. So most recently, we actually have a team on the West Coast that just does all my radiology reads. Amazing. And also our endocrinologist can beam wherever in rural America, or a stroke specialist can beam wherever. That's unusual to the VA. But the whole where's the patient and where's Dr. Joe license is, I think, what you're referring to, because they're not going to cover what's illegal. And those are driven primarily by state law. And it also brings me to the big point that what's one of the biggest barriers for telemedicine? It's because we have too many doctors in Massachusetts and they're not scattered everywhere else. So right now I have to essentially get licensed in every state, which is an annual thing. It's a payment, it's a paperwork filing, and there's good reason for there to be board of every state. But that's a massive barrier. So essentially, if I wanted to practice in multiple of these other states, so you'll see these advertisements, I typically have to get 5 or 10 different licenses on top of the Mass license. So this is an extra cost of about $20,000 to $40,000 for the physician to bear. So there's been a lot of talk of, hey, if Dr. Joe is licensed in Massachusetts, she should be good to go in Texas, or maybe we can do a federal licensing. So that's a big hurdle that I think we need to address on a policy standpoint, which is, that would be huge for the country if because Massachusetts has so many specialists, could just beam across the country. That would be great for rare diseases. It'd be great for LGBTQ. It'd be great for stroke. It'd be great for everything.
Totally agree.
Thank you so much. All right, now I'm going to turn to one of our pre-submitted questions because I think it's a good one to close on. Marianne writes that she thinks telemedicine is pivotal for so many reasons. She's a breast cancer survivor and advocate, and having it come to the forefront of mainstream health because of the pandemic has been wonderful for us in the breast cancer community. But now she wants to know, she's saying it seems to be receding. What can we do to ensure that it stays in place and that the remaining barriers of access, barriers to use are addressed? So let me start with you, Christina.
Yeah, so it's a great question. Thank you. I think the patient voice is very important. You are a great example of an important patient voice. I'm sure others in your group are also great voices, as is yours. We are doing all that we can to continue to push for policy change to be able to keep these modalities concretized. That would include maintaining payment parity for face-to-face versus telemedicine. Right now, there is payment parity, but if insurance companies, public and private, start dialing that back and start paying less for telehealth modalities than physical health, there will be a push by the medical establishment to crank back up the face-to-face visits. So I think leading policy, having patients advocate for concretizing policy that will ensure that patients get continuing access to telehealth modalities. And I think that there is some good news here too. For example, on telehealth, not only has it given patients access to telehealth, it has also given caregivers the ability to work from home on certain days. This has become a competitive issue. So now when, and particularly during the Great Recession, if let's say a doctor, a primary care provider was interviewing for a job, one of the things that they would be looking for, depends on their lifestyle and their preferences, but most doctors would be looking for at least one day from home doing telehealth. So if telehealth recedes, and there are some employers who are willing to do that and some employers who are not, I think it will become a competitive hiring and retention issue for skilled clinical resources. And I think that that's positive momentum on our side to maintain telehealth modality as a concrete part of the US healthcare system.
All really great points. And to Christina, to your great point, the biggest problem is that so some of the policies are kind of firm depending on how it's covered and how it's not, like it's on the federal level, Medicare, Medicaid driven, or if it's on, because Mass passed our own legislative chapter 260 Acts of 2020 coverage, which, these change at different times. But fundamentally, we don't necessarily have coverage guaranteed. And we're kind of at this place where there's a lot of, I don't like the word lobbying, but advocating for coverage. And I think that just has to continue to make sure we get coverage. So there's the coverage whole, like paying for it, but there's the incentives piece, meaning paying for it at the same rate as an in-person visit. So hands down, our most important piece, and that whole physician licensure thing. Patients should be able to move, and I should still be able to treat you. You should go take a vacation and still call me. But I do want to take this opportunity, since we're closing up, and you guys have been so wonderful for joining us and so passionate. Thank you to the Boston Globe of painting the future of virtual care and what that might look like. So I'm going to just say that we're working really hard on blood tests of the future. So COVID, you saw the ability to go past me. You should be able to go past me. I don't want to prescribe every lab test that you get, but also lab tests at home. We have very much advanced, and the federal government has supported some of this, and I mentor a couple of these startups, lab tests that can be done in the house, or can be done in the house and then mailed somewhere. And like interstitial fluid, where you can just pop a patch on and I can get continuous reads of blood tests. We are very far advanced. If you're thinking Elizabeth Holmes, but Elizabeth Holmes is actually like the technology is here. So we have that. And right now there's some telemedicine platforms that will actually mail out a vitals kit, meaning they'll mail out an otoscope to look at your ear. They'll mail out a stethoscope to listen to your heart before you get the telemedicine visit, and then you just mail the package back. But as I mentioned, we have a breathalyzer now that can just give 10 continuous vital signs readings. So if we allow virtual care to go forward, telemedicine care to go forward, imagine how much we could do in your home if you just allow the technology to take us there and the policies to support it. And I think it's going to go a long way in terms of health equity overall. I think we've seen really impressive numbers of how much of the Medicaid, Medicare population uses this. And then also in clinical trials, as we move to real precision medicine, so that I'm not giving you the wrong antidepressant or the wrong dose of Coumadin. So I'm very excited about the future of virtual care and delighted to be here. I'm going to pass it over to either Christina or Anna.
Okay.
I know we're over time, so.
Yeah, I just wanted to thank you both so much for joining us today, taking the time to be with us. Christina Severin, President and CEO of Community Care Cooperative, and Dr. Jennifer Joe, a physician at the VA and also CEO of Amplify for Healthcare. I wanted to thank very much our sponsor, Dan Sensi of Issues Management Group, for making it possible for us to be here today. I'm Anna Kuchment. I'm the medical and biotech editor at the Boston Globe. We're always happy to hear from you, your stories, your ideas for coverage. You can contact me at anna.kuchman@globe.com. My email is also on the Globe website. Thanks again to all of you so much. Have a good day.
Thank you to the Globe.
Dr.
Thank
Joe.
you, everyone.
Bye.